Hello everyone, this is about antenatal scans of 28-year-old lady done at 16 weeks of gestation and also at 18 weeks of gestation. You can go through the images and you can think about the findings and differential diagnosis, and if possible you can think about the final diagnosis. You can please go through all the images, it's very important, and you can go through the differential diagnosis. You think about the differential diagnosis, and also I think it's easy to have the final diagnosis. If you want more time, please pause the video and go back to see the images of the baby. Are you ready? Let's go. Now you can see that we are dealing with monochorionic diamniotic twins, and one of the twins is smaller and the other one is looking normal. And we can see velamentous insertion of umbilical cord from the polyhydramniotic F2 fetus, which is looking normal, whereas we have got oligohydramnios around the smaller shrunken F1 fetus with reduced abdominal circumference and femoral length. And there was no bladder in F1 fetus and there was distended bladder in the F2 fetus. Now we can give the differential diagnosis. By saying it, we can immediately say that it's a stuck F1 twin. The second differential diagnosis is inter-twin transfusion syndrome. Then the third one is twin-to-twin discordance with F1 being showing IUGR. And the fourth one is anemia polycythemia sequence in the twins. So this is the four differential diagnosis I am giving. Now we'll go to the differential diagnosis of a stuck twin. So stuck twin, so especially in the first trimester or the second trimester, it's very common in the second trimester. Whenever when you have stuck twin, so you have to think about bilateral renal agenesis or bilateral multicystic dysplastic kidney. So that's again. The second one is twin-to-twin transfusion syndrome, TTTS. The third one is premature rupture of membranes of one of the gestation that may give oligohydramnios and the twin will be stuck. The fourth one is rare, but again it's not less common due to severe IUGR in the second trimester. And last one, very rare to have chromosomal aberrations by stuck twin. Now we'll go to the inter-twin transfusion syndrome. So that's usually only in monochorionic twins, and it can occur even in monochorionic multiplets also. And the second one is inter-twin transfusion. You can have balanced transfusion syndrome or unbalanced transfusion syndrome. When you say balanced transfusion syndrome, it's very common with smaller growth curve in one of the twins and the other one showing appropriate growth curve. This is common, almost 30% might be having, otherwise no restriction, but there can be changing in the growth curve. And less common is one being growth restricted and the other one being normal. So the growth restricted may be having due to aneuploidy, which will have symmetric IUGR, whereas asymmetric IUGR you can have uteroplacental insufficiency. Fetal changes also might be having IUGR. Now we will have unbalanced transfusion. In the unbalanced transfusion, there are three varieties. So first one is acute variety, is twin-to-twin embolization syndrome, TTTS. The second one is chronic. The more common is twin-to-twin transfusion syndrome, which is called as TTTS. And the third one, reverse unbalanced transfusion, is twin reversed arterial perfusion, which is otherwise called as TRAP. Here we are dealing with twin-to-twin transfusion syndrome, TTTS. So that's the diagnosis. Complications unique to monochorionic twins are TTTS, or it can be TAPS, the twin anemia polycythemia sequence, or it can be TRAP, which will be twin reversed arterial perfusion sequence. And you can have conjoined twins, which can be symmetric or asymmetric conjoined twins. And you can see the picture of a twin-to-twin transfusion syndrome. You can see the placenta and the umbilical cord, which is having either venous arterial anastomosis or artery to artery anastomosis or arteriovenous anastomosis. Very less common to have veno-venous anastomosis, which doesn't give much information, much troubles in twin TTTS, but it can be due to some changes like already we talked about, smaller growth curve in one and appropriate growth curve in the other. It can be due to the veno-venous anastomosis. When will you give the diagnosis of TTTS? It should be monochorionic diamniotic twins when you have only one placenta, and the second one is you have got hydramnios in one sac and oligohydramnios on the other side, And third one is growth restriction. Growth restriction, especially with the biometry, you might have. So these are the three criteria to have TTTS. Quintero staging system is commonly used. So the first one, stage 1, is oligohydramnios in donor twin and hydramnios in the recipient twin. And the second one is urine being not visible in the bladder of the donor twin and the smaller twin. And the third one is critically abnormal Doppler studies of the umbilical artery or umbilical vein or ductus venosus. And that's what we have been seeing in our case. This was a stage 3. And fourth one is hydrops of either twin. And the fifth one is demise of either twin. So the additional sonographic risk factors usually, even in the first trimester, you can think about is crown trunk length discordance. If it is there of more than 20 to 25% between the twins, you have to think about this. The second one is nuchal translucency. If you have got 95th percentile, more than 95th percentile of one, or there is discordance of more than 20% between the twins, we have to think about TTTS. And when there is ductus venosus reversal, absence or reversal of ductus venosus A wave, you have to think about this in monochorionic diamnetic twins. The second trimester is more common. The discordance, abdominal circumference discordance will be, you can see in fetal biometry. And when there is membrane folding, if it is there, placental side, then you can think about it. And there is filamentous placental cord insertion, again what we have been here, again it's a criteria for TTTS. So when there is stage 1 TTTS, usually it has a good prognosis, and almost because more than 75% of cases remain stable, even though there will be some changes between the oligohydramnios, polyhydramnios changes will be there, but otherwise the growth rate will be okay, proper, and no intervention might be needed. But now, before going to stage 2 itself, I think intervention is being done regularly, right? This was given as a quiz through Google form, and many of them have given the correct diagnosis, and I congratulate all of you. Please go through the other quizzes which are dealing with the trap sequence as well as the conjoined twins. You can go through that and give your comments. Thank you very much. Take care.